And today it's my pleasure to be able to chat with you a little bit about our work in prevention science and our work in particular, our series of studies with United States military families, families in which a parent's been deployed to Iraq or Afghanistan. So most of my work is done at Arizona State University in the psychology department, but I do spend one semester a year at the Hebrew University of Jerusalem in the School of Social Work. As Mark mentioned, our research spans the United States and other parts of the world. I'm primarily going to talk with you today about the work in the US and the work with military families, but I'm happy to chat later about anything else that we're doing. I also want to say thank you, Jamie, you're there, I see, for inviting me. So I know you know a lot of this, and I'm guessing that there are several prevention scientists in the room, virtual room, but you know that prevention science is interdisciplinary, it's team science. That's what I love about it. I've been a prevention scientist now for about 20 years. It's a fantastic discipline, and it's really exciting to be able to collaborate to improve public health, improve individual and public health through science, and to work with people in as varied fields as biomedical engineering, computer science, as well as public health and psychology and social work. So, of course, the kinds of research questions that we ask in prevention science are how, what, and in what contexts behavior change interventions work to promote health and reduce risk for disorder. We focus on theory-based interventions. I'll talk to you a little bit about the theory that we work from. We're interested in understanding mechanisms of action, so how things work to change people's behavior, and what moderates intervention effectiveness, what variables lessen or magnify the benefits of a particular program. But prevention science more recently is also about how programs that we know to be effective, and certainly in the United States, there's a good number of them now that have been proven in efficacy and effectiveness trials to really move the needle on reducing risk behaviors or improving sort of resilience of children, families, adults, populations. The challenge now is how to get those programs to people, so how to reach populations and engage children, youth, and families, as well as how systems and settings uptake effective programs. And of course, you have a few programs that you've done a great job with disseminating and implementing widely. But dissemination implementation science is really where I think is the sort of cutting edge of prevention science. So, for example, a couple of years ago, we were really interested in understanding how we could use targeted social media marketing to facilitate engagement with a digital parenting program. And I can certainly talk a little bit more about that later. So over about the last 20 years, our little village of students, postdocs, and professional staff have developed and tested parenting programs for families who, broadly speaking, have been exposed to some kind of traumatic event, usually through wartime deployment, though we've also conducted studies with families exposed to domestic violence, homelessness, and war. At the very end, I'll tell you a little bit about an ongoing study that we have with refugees and migrants to the United States. We've conducted 4 randomized controlled trials. We're on our 5th. That have been US government funded, about 1,000 families, a little bit more. And we gather data at multiple levels using multiple methods. That is anything from physiological and genetic data to self-report data, data from parents, children, and children's teachers. And I should note that we use intent to treat analyses. So once families are randomized, they're always analyzed. I suppose I shouldn't get to the very end of the story at the beginning, but we've been very fortunate that the program that we've been testing has shown meaningful and sustained change in families' lives in terms of changing parenting, parents' mental health, children's adjustment. But of course, that's not good enough. You want to be able to get the program out to people. We're currently testing our Parenting in the Moment program, which is an online-only parenting program, self-directed program for refugees and migrants to the United States, and it's in Spanish, English, French, and Arabic. And so we just started a few months ago, randomized trial of that. But like I said, I'm mostly going to be talking about ADAPT, which is a program that we developed in 2011 and have been testing ever since with US military families. ADAPT is based on the social interaction learning model of Patterson, Gerald Patterson, Marion Forgatch, and others at the Oregon Social Learning Center. And so essentially, Patterson, who was developing his theories since the 1960s when he got his PhD at the University of Minnesota, after he had been in World War II as a 17-year-old and been awarded the Purple Heart and the Bronze Star for his bravery on the island of Okinawa. Patterson came back and was really interested in understanding what goes wrong in families and why kids get into trouble. And so he developed a theory that he called coercion theory, which posited that in interactions with their children, parents and children develop these coercive patterns of interaction. So the model is a combination of social learning theory and social interaction theory, hence it was later called social interaction learning theory. Unfortunately, Patterson wasn't satisfied with sort of figuring out what it was in the coercive interactions between parents and children that later got children into trouble. And there on the cylinder in the yellow, those are aversive behaviors. Escalation, negative reinforcement, negative reciprocity. If we had more time, I'd have fun doing a role play with you, but you'll see a little bit in the video I'm going to show. But Patterson was also interested in understanding how we could replace those, how we could teach parents who'd got into these coercive cycles with children to learn positive parenting behaviors. And indeed, the Oregon model of parent management training, which is one of the oldest and most well-established parent training models, essentially teaches parents positive parenting skills. What you find is that both positive and coercive parenting practices contribute unique variance in child outcomes. But rather than teaching parents to reduce the number of coercive interactions they have with their children, we instead teach parents how to replace those negative interactions with positive interactions. We use a lot of RAPs. Parents are their children's best teachers. Use a 5-to-1 ratio, 5 positives for every negative. Shine the light on what you want to grow, which is essentially focusing on and growing positive behaviors and things like that. The 5 behaviors that you see, the 5 positive parenting skills that you see here, skill encouragement, limit setting or discipline, monitoring, problem solving, positive involvement, are incorporated into the classic parent management training Oregon model. In our work with parents affected by traumatic stress, we add an additional component. So we were particularly interested in adapting traditional parent training models for families affected by trauma. And what we hypothesized and studied prior to developing the intervention was what happens in families where, say, a dad returns from service in Iraq or Afghanistan with post-traumatic stress disorder symptoms. And what we hypothesized was that PTSD symptoms, whether or not the dad or the mom, whoever, had both parents, sort of whether it was diagnosable, that those symptoms would manifest in harder interactions with children, particularly focused on emotions, that parents would be more avoidant of children's negative emotions, possibly more negative in their emotion coaching in the sense that they might minimize, dismiss, or even punish children's negative emotions, because, of course, at the core of trauma exposure and its reactions are symptoms around sort of avoidance and wanting to escape trauma triggers by either psychologically or physically. One classic example, I think, is the 10,000-yard stare that you probably are all familiar with, and we have a sort of a picture in our manual of a dad looking into the distance in the field of battle and the child trying to get his attention. And so what we did was we added a sort of key component to these 5 components, which was what we call emotion socialization. And essentially that is a combination. Emotion socialization is a term developed and sort of really pioneered by Nancy Eisenberg in Arizona. And emotion socialization refers to the ways in which children learn about emotions. And those are sort of 3 ways. Discussions about emotions, parents' responses to children's emotional presentation, emotional expression, and parents' own emotion regulation. And what we teach that is by using sort of Gottman-esque emotion coaching strategies, which I can talk about if anyone's interested. And we also teach parents emotion regulation skills via very short, very brief mindfulness exercises that are delivered throughout the curriculum. So that's a little bit about the content of ADAPT. I think the best way, telling is never as good as showing. So what I'm going to do is I'm going to just show you just 3 minutes of one module of one of our components. It's the first core skill that we teach parents, which is if you want your child to do something, how might you go about talking with them about it? So I'll just give you 3 minutes and let me know if you don't hear.
Give effective directions. Giving effective directions is one of the most powerful steps that parents can take to improve children's cooperation. Unclear directions lead to conflict.
Come on, guys. Time for baseball practice. And what's the holdup? Let's go. Jeremy, Henry, get down here right now. Come on, let's go. Move it.
I don't want to go to stupid baseball practice. This sucks.
Get your hats and gloves on ASAP. Come on, guys, get it together. I shouldn't have to wait on you. When I ask you to do something, that means do it.
We didn't hear you.
Well, clean the wax out of your ears.
What is going on,
I'll
guys?
tell you what's going on. I told these guys at lunch we needed to leave at 2:45. It's almost 3.
You guys, we've talked to you about being late. You should know better.
Yeah, you should know better. How many times do we have to go over this?
All right, Jim, they've got the point.
No, I don't think they
We
do.
got the point.
Thanks. Now they're talking back to me. Thanks a lot.
Well, arguing about it is not going to get you there any faster, so you might as well just go.
Come on, guys, get in the car. We'll talk about this after.
That didn't feel good. When you don't give clear, effective directions, you can get into disagreements with your children.
Let's go. Move it.
Kids can get in the habit of not minding or talking back, and they don't learn to follow through. Let's watch Dad try a different strategy.
Jeremy, Henry, it's time for baseball practice. Please put your game away now and get your hats and shoes on.
I don't want to go to stupid baseball practice. This sucks.
Thanks for getting ready, guys. You're a big help. I really appreciate it. Hey,
Quite a different outcome. This time, Dad gave directions that encouraged the kids to cooperate. He avoided conflict, threats, and coercion. These kinds of directions work and build positive relationships. First, Dad stays calm. He checks his emotions. Instead of yelling, he gives the direction in close contact, less chance of not being heard or being misunderstood. Now that Dad has the boy's attention, he gives a short, clear, and specific direction using the child's name and the words please and now.
Jeremy, Henry, please put your game away now and get your hats and shoes on.
A direction like this is easy to understand and to follow. Dad remains calm. He waits for 10 seconds. He doesn't get drawn into any arguments. In most cases, waiting those 10 seconds is all it takes.
Thanks for getting ready, guys. You're a big help. I really appreciate it.
And once his kids comply, Dad makes sure to follow through by expressing his appreciation. Praise powerfully reinforces behavior and makes it more likely that kids will follow directions in the future. Giving effective directions.
Okay, I think we'll stop there because you get the idea. And if I was in the room, we would have some opportunity to debrief it a bit. I think it's so when we do our groups, we actually don't show this video. This is for the online program, and parents can go and see this on their own time. in the group, we role play instead, and the debrief's always a lot of fun. And what's most fun is coming back the next week when we've asked parents to go off and try effective directions. And we've run about 40 groups, 50 groups, probably more. And we've never had any group come back where at least a number of parents haven't said, wow, this seems so simple. Of course, it's never as simple as it looks on the video, but it's really something that's relatively low-hanging fruit. And once parents realize that they can change their behavior, it can really encourage them to keep going. I think the other reason I love this video is because it's really a good example of the coercive process, how angry dad escalates, the kids escalate, and then the mum comes in, and then it gets even worse. And especially we'll talk about this later. So that's just a little snippet of what the program looks like. I'm going to zip through. I'm going to give you a whistle-stop tour of 3 randomized trials that we've done on the program, each with a different goal. And so the first study we did was in 2010 to 2016, funded by the National Institute on Drug Abuse of the National Institutes of Health in the United States. And that was really focused on testing the original program that we developed with NIDA funding, which was the group-based, a multifamily group-based 14-week parenting program. I want to say that at the time, there was really very little attention paid to families. In fact, in the military, one of the favorite sayings of the military leaders I would meet would be, if the military wanted you to have a family, they would have issued you with one. And so eventually, especially after the surge, when far more troops were sent to Iraq and Afghanistan in 2008, 2009, 2010, there was recognition that, hey, families are not doing so well. And ADAPT is still the only parenting program developed and tested for and with military families with school-aged children. So we're pretty proud of that, even though later on we can talk a little bit about the challenges associated with implementation. We developed it originally for National Guard and Reserve families. That's the NGR you see. Those are civilian soldiers. I know you have a reserve component in England also. And these families live in civilian communities. They are, for all intents and purposes, civilians, but a member or both members, one parent or two, go off 1 weekend a month for drill, and then 2 weeks in the summer. And until the wars in Iraq and Afghanistan had never been deployed to war. But since 2001, National Guard and Reserves have been deployed on an unprecedented level, and then have to come back after a year or even 2 years or even more than 2 years deployed to a family that looks really quite different. We recruited, and that was why we were really committed to working to developing this for National Guard and Reserve families. We recruited 336 families, and they were randomly assigned in a straight effectiveness trial to either the group-based parenting program, 60% or 40% to resources as usual, web and print resources. We followed each family for 2 years. We gathered parent, teacher, and child report data at baseline 6, 12, and 24 months. We were interested in understanding, obviously, does the intervention change parenting, not based on what parents tell us, but based on what we see, so observations of parenting, and of course, child adjustment, so behavioral and emotional programs, substance use. This was a NIDA-funded study. We were also interested in whether we could shift the needle on parents in terms of their emotion socialization, emotion regulation. So these were children in Minnesota, children with parents deployed to war from Minnesota in the Army, Navy, Air Force, Marines, and Coast Guard Reserve. We had about 15% of our sample was deployed moms. It was a pretty stable sample. You can see married about 10 years, first or second marriage, in pretty much considered middle class families. You can see the mean family income here. And I'm just going to jump to findings because I've relatively a small amount of time, and I want to make sure that we're able to cover all 3 of our studies. So essentially, we randomized these families in a straight effectiveness trial to get ADAPT, to be invited to ADAPT or not. I should note that it's not written here, but about 70% of the families who were invited actually showed up at least one time. And of those who showed up at least one time, they did show up for the majority of the program, which was quite remarkable considering we were asking them to come on a weekday evening, because weekdays generally worked better than weekends, with their children. Their children got childcare, which was unrelated to the program. They got pizza for dinner. Some of them drove more than an hour to get to us, which I think is a reflection on how few resources there are available for military families. And they really got a lot out of the peer support in the program. So what we found was that the program indeed did improve observed parenting using ITT intent to treat analyses at 12 months, and that was associated with both contemporaneous and subsequent reductions in child internalizing and externalizing symptoms using multi-agent reports with latent variables, parent, child, and teacher. And that we published in 2018 in Prevention Science. Those improvements in observed parenting predicted later reductions in youth substance use. That should say youth substance use intentions at 24 months post-baseline, because our kids were pretty young. They were were actually 4 to 12 at baseline. So at 2 years, they were still, the oldest was only 14. So we looked at substance use and intentions. And then what we found, which was very interesting, was that even prior to seeing changes in observed parenting, we see improvements in parenting efficacy. And those improvements in parenting efficacy mediate reductions in parental PTSD, depression, and suicidality at 1 year. And we wouldn't have thought about looking at those data. Our colleagues at NIDA asked us if we'd be interested in examining those data, and we did indeed see that. The program has actually a main effect. It doesn't have a main effect on dad PTSD, but it does. The program itself, there we have an ITT effect on reducing mother's PTSD symptoms over a 2-year period. We don't reduce dad's PTSD symptoms, and we hypothesize that that's because our dads are more likely to have PTSD. They have more severe symptoms than our mums do, both because fewer mums were deployed, and in general, across the mums, we have fewer symptoms. We also had we had significant impact on experiential avoidance and emotion socialization, not in the way that you might think, but not surprisingly, our mums practice mindfulness more than our dads. We didn't have more mums. We had slightly more mothers show up to groups than dads, but we had mothers. Mothers were the first ones to sign up for the study, and they had to generally bring the dad in. So we weren't surprised that they generally practiced more than dads. And of course, and what we found, not surprisingly, was within the intervention group, the participants who use the online mindfulness exercises more, who practice more, showed more trait mindfulness at 6-month follow-up compared to baseline. We did see reductions in both moms and dads' negative emotion socialization as a result of the intervention, and that was associated with reductions in child internalizing symptoms over 2 years. And that is what you would expect, that if you can move the needle on emotion socialization, you can see reductions in internalizing. What's interesting is that so what we're seeing, what you might be asking, what is negative emotion socialization? So simply stated, it's parents saying things like, big boys don't cry, stop your crying. Why are you feeling scared? There's no reason to feel scared. That's essentially sending a message to the child that negative emotion states are unacceptable, not a way to be, or to, and that makes it quite hard. And that we know from the emotion coaching literature that those kinds of parent responses are related to increased risk for child internalizing. So we were glad that we moved the needle on negative. We didn't do such a great job at improving positive emotion socialization. We were able to do it with mums, but not with dads. We could talk about that if you're interested. Because we had really interesting findings on dads, because we were able to move the needle more generally with mums than with dads, we were really interested in, and because most of our dads were service members, we were really pleased to collaborate with Jim Snyder, who actually got a separate grant from NIH to understand a little bit more how PTSD symptoms might manifest in parent-child and co-parent interactions. And essentially what he found was that the intervention really did well with fathers who were very high in experiential avoidance at baseline. And what happened with those dads were that when they were with their children, and the children were showing distress, emotional distress, fathers didn't exactly punish them, certainly not in front of the camera, but they did, they sort of brushed the child's negative emotions under the carpet as much as possible. What Jim Snyder called rapid soothing. So, oh, let's play a game. Let's think of something fun. Oh dear, and then let's move on. Those dads in particular really benefited from the intervention, and what we saw over a 2-year period was that those dads showed significant reductions in their distress avoidance with their children as a result of the intervention. I'm not going to spend much time on this, but we showed some findings below the skin. We're particularly happy with a paper that we published last year in Prevention Science, showing that some of our dads, about 1/3 of them, who had a genetic vulnerability to problem drinking in the context of high levels of combat stress. So we know that combat stress is associated with increased drinking, but dads with this DRD4 genetic vulnerability had much higher rates of problematic drinking, and the intervention really dampened that risk. So that was one thing, and we replicated in that paper. We were trying to replicate something that Jean Brodie had found. Jean Brodie and their group at Georgia had found actually with adolescents in the DRD4 gene. We also did some heart rate variability investigations, and we found, interestingly enough, that dads with better vagal flexibility benefited more. So sort of interesting, the dads that benefit more are both high risk and high, more protected. We didn't move the needle so well on the average dads. So that's a bit of a summary of the program impact, and we've done the vast majority of our papers, obviously, on the first study. But let me move on to tell you a little bit about what we did in the second and third studies that we're just sort of getting papers out on now. So a second study that we did was our comparative effectiveness study. And what we realized after the first study was that it's great to have a multi-family group-based intervention, but as everybody knows, not all families can make it to groups. It's a big commitment. It's also costly. And of course, especially if you think about military families in the Reserve and Guard, and I'm sure this is the same in England, they live everywhere, especially in rural areas, and we just don't have service providers for them. And so what we did was actually simultaneously with developing our group-based intervention, we also developed an online intervention. It started as a sort of online supplement in this first go-round in this first effectiveness trial. But in Adapt for You, we developed it as a standalone program, Adapt Online, and we also developed an online facilitator-assisted program, which we call telehealth. And what we wanted to do was do a comparative effectiveness trial of these 3 interventions, essentially these 3 program formats. And a comparative effectiveness research design, also called a fixed allocation design, compares 3 groups to determine which one's more effective. There's a single randomization. So you're either randomized to online self-directed, which consists of like 10 modules of the video you just saw, plus lots of other things, home practice assignments, some summaries of some practice videos, things like that. The group-based intervention, which I told you about, which we tested in the first study, and then this telehealth mode, which essentially consisted of a single facilitator with a single family meeting on Zoom once a week for an hour. So the group-based was 2 hours, the telehealth was 1 hour, and the online program could be done sort of whenever you wanted in your, time, place of your choosing. So parents just logged on from home or wherever they were. In this study, we had 244 families from Minnesota and Michigan. They were mostly still Guard and Reserve, with some active duty people who were veterans who'd retired. Again, same inclusion criteria: at least one parent deployed to post 9/11 wars, and at least one child between the ages of 5 and 12. We did the same analyses at 6, 12, and 24 months, and our outcomes were the same. So when we look at it, we're just submitting the revision on a paper on engagement with this study. So if we look at, one of the things we're really interested in is comparing participation, so enrollment and attendance across the 3 formats. And what we found was that the enrollment, not too surprisingly, was much higher. And when we say enrollment, we mean, you showed up at least once. So 54% of those assigned to the group format showed up at least once, significantly less than the 70% in the first study. And that's likely due to, we did this in 2 states. The waiting time was quite a long time. It was quite hard to pull a group together because you needed sufficient numbers and you needed to make sure they could all do the same evening. And so we're not surprised that the enrollment for the group-based format was low. But as you can see in the self-directed and telehealth formats, it was much higher, and those weren't significantly different from one another. Once families attended, the ones in the group format attended about 2/3 of the session. So we still got decent attendance even in the group. In the telehealth, you can see the attendance was fantastic, almost 90% and 83% in the online format. And basically what we want to see it was a non-inferiority hypothesis, which was that essentially what we were asking was, what we were hypothesizing was that the face-to-face formats, whether they were virtual face-to-face as in telehealth or in-person group, would be equivalent, but that they would both be superior than the online self-directed format where you don't get the advantage of being with a facilitator. And so that's the analyses that we did. And in the next slide, I can reveal the results, which show that in fact, group and telehealth were non-inferior to each other. Both were superior to the online self-directed, and that just came out online first in JCCP this month. I think one of the biggest downsides of this is because we already had a 3-group comparative effectiveness trial, we did not have a control group. So what we can't say was the online self-directed better than nothing? Although we're working on that, one of the things we're looking at doing, and be really interested if anyone's got some ideas about this, is pooling our data from the first and second studies to see if there's some way that we can figure out maybe change for the online group. The third, I'm sorry, I hope I'm not moving like too fast, but I know I've only got about seven minutes left, and I really wanted to get to the last study, we actually have done 4 randomized trials. The one I didn't talk about, it was a small RCT of just the online program that we did a long time ago and haven't really published on. Was really just a proof of concept for 4 modules of the online program. But this is our 3rd large-scale trial, and this is a trial that we've literally just finished a few months ago. And this was our Adapt Smart, and they say what doesn't kill you makes you stronger. This is a study that we started in 2016 2017, I should say, that had so many challenges. And then, of course, we were just getting up and running with successful data collection and recruiting people, and then COVID hit in 2020. And so this was really something that we ran the gauntlet on, and we've actually got a paper in that's also under revision that talks a little bit about how we had to pivot, and I can tell you a little bit about that if you're interested. But the idea behind a sequential multiple assignment randomized trial as opposed to a fixed allocation design like the comparative effectiveness study that we did or the first effectiveness study is that we're trying to understand how to tailor programs for individual needs and preferences. So basically, most interventions use this one-size-fits-all, but it's inefficient. Some people want or need less or more than they get. And so a SMART compares different formats and sequences of an intervention. It produces concrete intervention strategies that providers can actually use immediately. And so we were able to do this because we had multiple formats of the program that we had tested, and we also had prior effectiveness data, and those are really prerequisites for SMART. So essentially, our SMART tested intervention strategies, that 4 intervention strategies that are depicted in different colors on the right-hand side of this diagram. The first, and basically in a SMART, you have to define what's a responder, because essentially what you do is you randomize people to one intervention or another. And then if they're responsive to the intervention, then that's great. They stay the course and continue with what they got in the first place. If they're non-responders, you then re-randomize them to another one of two, in our case, interventions. And these SMART trials are very prevalent, very, very frequent in medication studies. They're less frequent with behavioral studies, though, Jamie, I think you're doing a SMART. And they're really cool ideas, but in practice, they're kind of killers, but we can talk about that later. But essentially what we were interested in terms of understanding about response was we weren't interested in whether people showed up. For us, a responder was someone whose parenting was about at the level that we would want it to be. And if you'll recall, I told you that in our first study, the first thing that we were able to move the needle on was parents' self-efficacy, parenting efficacy, or parental efficacy. And that moved pretty quickly. And that in turn indexed changes in observed parenting or improved observed parenting. And so what we did was that we used as our response variable the parenting locus of control measure, a very brief 20-item measure that parents completed, as you can see, at week 4. So essentially what we did was we first randomized people either to receive the online self-directed condition or to be in a condensed group. So, I told you about our 14-week group. This was a 2-day workshop. 1 day was done, and then 2 weeks later, the second day was done. So these were like 2 Saturdays, 2 weeks after the next, or in the third week. And then after parents went through either the online or the workshop version of ADAPT, we asked them to complete this brief 20-item questionnaire about parenting efficacy. And if they were above, we hypothesized based on prior data what a responder would be. And if they were above the line, they stayed the course. And if they were below the line, we re-randomized them. So where you see R2, either to a booster individual face-to-face, so 3 sessions, or a booster group face-to-face, also 3 sessions, but in a group of families. And so, as you can see, what we're looking at is testing which first-line intervention strategy works best. And if you needed a booster, what combination of the first and second would be most effective? This was to make things even more complicated. I'll probably never do that again. It was a 3-site SMART with an allocation ratio of half, 1 to each group. So basically we randomized within large army bases, Fort Bragg, Fort Campbell, and Fort Belvoir and Meyer. We also initially were interested in looking both at regular army soldiers and also families of special operations forces. They're frequently deployed. So initially, we also randomized within those blocks. I'll tell you what happened later. We recruited 420 families, blocked by geographic location and whether they were regular army or special operations. I told you about the first and second line interventions, and there's a little bit about same measures, multiple method, and gathered over 4 time periods. I think because of time, I'm actually not going to go into these very sort of more detailed diagrams, but those show you that essentially we ended up with 290 families who were randomized in the first round. I think what's really cool is that our non-responders and responders fell out. Like, we were concerned that we might get, either everyone would be a non-responder or everyone would be a responder. And it fell out pretty much as we had predicted. So that was cool. And as you can see, we ended up with sufficient, less power than we wanted, but sufficient to be able to do the analyses. I'm going to skip this just so I can take you, and I'm going to skip the analytic strategy, but we followed Billy Nahum Shani and Danny Almoral's advice on analysis. And essentially our results indicated a pattern where what we found was that in the first round, online was superior to workshop as a first line intervention, which actually we found to be pretty cool, because actually in a first round, we want to provide the lowest possible dose of an intervention. For the non-responders, group was the superior second line intervention over individual, and the combination of online followed by group was superior to other combinations in the outcomes that are listed below. There were some benefits also to other combinations. For example, workshop followed by individual, improved mother's parental self-efficacy, but reductions in PTSD symptoms were superior in individual. Reductions in mom's PTSD symptoms was also superior in the online and individual sequence. And then, but for non-responder moms, so for non-responder moms, starting with online and then moving to individual was better than group. So again, we've got some hints for moms who are symptomatic possibly. So better than the standard, online followed by group might be online followed by individual. So I think I told you the caveats and challenges that we had in this SMART, and we had a really great difficulty getting 2-year follow-up data given the 1-year hiatus that we had with COVID. But I'm again happy to chat about that. I'm not going to talk about our ongoing and future studies unless you want me to. I think I'll move to questions and just say thank you.